I've directed this talk really for patients. The clinicians obviously will know a lot of this, but I think what I've done is highlighted a pathway in the way I explain these issues to individuals with aniridia. So the first point, which I think you need to get across, is that there are multiple reasons for reduced vision in aniridia, which are itemized here. Firstly, macular hyperplasia, which is the benchmark limit to the amount of visual improvement for most patients in aniridia. There is a finite level to which the vision can be improved, even with cataract surgery. Secondly, the iris is either reduced or absent, and that's going to affect the way the light enters the eye. There may be secondary glaucoma, which can limit the vision, corneal opacity, which we'll be hearing about later, and for my emphasis today, the development of cataract. So I'm just going to go through the pathways in making this decision. So first of all, the retina, as we've heard, is not fully formed. It's as though the photographic film in the camera, in this case the eye, is not sensitive enough to be able to make full use of the image that's being presented. And so, as I mentioned, that's the final limiting factor on the amount of improvement that can be achieved following cataract surgery. Second point relates to cataract surgery, but also to iris implants, is that the absence of the iris means that too much light enters the eye, and this causes dazzle and glare, which is termed photophobia, which is worse in situations of bright light. Third aspect is that integral to absence of the iris is that the normal fluid drainage mechanism can be either absent or damaged, and as a result, fluid can't escape from the eye. So these black circles indicate where the normal pathway for fluid to leave the eye are situated, and so that's at the root of the iris. And so in the eye with aniridia, there is a fine balance. So the outflow of fluid is reduced, but it may be adequate to maintain the pressure. But over time, that capacity for fluid to leave the eye can be reduced, and certainly surgery performed inside the eye, such as cataract, or more particularly iris implants, can further damage that. So they may tip the balance into a situation where the pressure was managed to a situation where the pressure is increasing. So if the pressure increases inside the eye, it can damage over time the nerve, the optic nerve from the eye, and that's called glaucoma. And so during the lifetime, the risk of glaucoma increases from approximately 10% at the age of 10 to maybe 40 to 50% by the age of 50 years. So there's a natural tendency for glaucoma to develop, and one of the thoughts and priorities of doing surgery is that this natural trend is not exacerbated, made significantly worse. And so the nerve itemized at the back of the eye by that black ring. The fourth aspect is that the surface of the eye becomes irregular. This is aniridic keratopathy. This is the result of a stem cell failure. So the normal cells that produce the smooth surface to the cornea are damaged or absent, and the result is that the surface becomes rough, unstable and irregular, which can also blur the vision. And finally, what we're talking about, the lens which is inside the eye, which is a major focusing part of the eye, can become hazy. I think everybody who has aniridia will over time develop cataract to all intents and purposes. So eventually 90 to 100% of individuals will develop cataract to some degree, and this can blur vision. And part of the decision making is to identify how much the cataract is contributing to visual deterioration. So those have itemized the reasons for visual loss in aniridia, so several reasons. Unfortunately, not all of these can be treated at the moment, but some of them can, and we'll just talk about that. So a cataract operation involves the lens inside the eye, and the central part of the lens is removed surgically, usually through a small incision, leaving the supporting structures of the eye, which are these fibers at the top and bottom, and also the capsule, which is the bag of the lens. And the new lens is implanted and supported within inside that capsular bag. That's a normal operation. So these are some pictures. So various types of lenses are used, but the normal lens, the point is that they're actually significantly smaller than the normal human lens in diameter, with a diameter of about 6 millimeters compared to 12 millimeters for the normal lens. And so what that means in the two bottom pictures is that the normal lens edge can just be seen at the margin of the cornea here, so that's inside the eye. But after the cataract operation, the lens which is implanted is smaller, so the bit which is used to focus the light is smaller than the whole diameter of the cornea, and light can pass around the periphery of that lens implant, which is a consideration when thinking about a replacement artificial or plastic iris implant. So what are the risks of having a cataract operation? So these are roughly the risks for everybody who has a cataract operation, which are about 1 in 10 of requiring a second minor procedure, usually performed by laser, to clear the pathway of light, 1 in 100 of reversible inflammation, 1 in 2,500 of having an infection, which can leave the vision significantly worse, and 1 in 10,000 of a problem such as infection or retinal detachment, destroying all useful vision from the eye. So that's for everybody, not just patients with aniridia. In aniridia, there are additional associated risks, and these are itemized here. First of all, if the cornea is hazy, the surgery can be technically more difficult for the surgeon because it's hard to get a good view to do the surgery in a controlled way. So there is an increased risk in doing it. The second point is that the visual outcome may not be as good as the patient had hoped or anticipated for the reasons I've described. There may be glare because the lens implant is of a smaller diameter than the normal lens, but that glare tends to reduce over time. It's harder, this is similar to point 1, it's harder to see into the eye, and therefore it's harder to treat any complications should they occur. The lens supporting structures in aniridia are abnormal. The lens tends over time to dislocate superiorly, and this may mean further surgery is required to recenter or replace the implant over years, and not usually an immediate post-operative period, but over years later. And any operation, as I said, to the eye can theoretically increase the risk of glaucoma. So the benefits for the individual are that it can improve the vision. Roughly how much in vision, it depends on the state of the retina, but normally one would expect about 2 to 3 lines of extra vision and reduction in glare. And so this is not normally going to give vision to see the bottom of the chart, but a reduction in glare and some improvement in terms of lines of visual acuity. This is in the short term, and by the short term I mean 5 to 10 years, but over time there is a gradual erosion of this benefit if other changes in aniridia progress, most significantly if the corneal opacity becomes more severe. So there can be benefit, which can be substantial, but over time this can be eroded. When to do surgery, how to make this decision, the most important point, I think, is that it's not an emergency operation, that there is no measurable risk in delaying intervention if you would like time to think about it. So it's safe to leave. And if you leave it, that's not going to materially affect your risks in the long term. It is, in any individual, it's a balance between the risk and benefit, and this is something you need to discuss with your consultant. And the risks are slightly greater in aniridia, and the benefits are slightly less. So that balance is not as clear as in an individual who has an otherwise normal eye. Placed on that from the surgeon's point of view, it's technically easier to perform the surgery at an earlier stage when there's a better view, rather than delaying intervention until the cornea is hazy, there's a very poor view, and a very dense and surgically difficult cataract to manage. Artificial iris implants, and so on the left slide is a normal iris, that's not an implant, and on the right slide is an aniridic eye with absence of the iris, and so you can see the lens within the eye and no iris, and the potential benefits of replacing the iris with an implant is to reduce glare, to improve vision because the glare has been reduced, and a cosmetic improvement by improving the appearance of the eye. So improvement in vision and also improvement in vision, in appearance. Broadly, there are two types of iris implants. There are solid plastic, they're all made of plastic. They don't function like a normal iris in terms of movement. So there are solid implants which are normally inserted at the time of cataract surgery, and they can be a black ring surrounding the focusing part of the lens in the center. They are much larger than a normal intraocular lens implant, and they require a large incision, which potentially can cause more inflammation and damage the limbus, which may already be jeopardized by the stem cell failure. It's not possible to put these large lenses within the capsule, and so they have to be supported by other structures. It's definitely not, I think, acceptable practice in surgery to support these lenses either in the sulcus or in the anterior chamber. They will not be stable, and they can cause continued inflammation and damage the cornea, which may require further surgery in the years to come. I think best practice now is to support the lens by suturing the lens to the eye wall of the eye, so that it's supported by a suture and not by the already damaged structures within the eye. And so I don't use these bottom ones. I think they're ineffective. The second option is a flexible lens implant. So these are foremost in this field is a company called Human Optics. I have no link with that company. They're able to manufacture irises which are really very realistic in appearance. This is sort of company, I think, sponsored pictures on the bottom here, which show an individual with aniridia with one eye done and then both eyes done. And so the cosmetic improvement can be spectacular because they're much more natural in appearance than the black ring of the previous types of implants. They can be folded, and so it can be posted inside the eye, and where they unfold inside the eye, but they still need to be, I believe, supported by a suture. It's not adequate, I think, just to leave these supported at the base of where the iris was, because that's the position where the normal drainage mechanism is, and that can be further damaged by the implanting the implanter there. So they need to be sutured. within the eye. The risks of artificial iris implants is they have a fixed pupil size, so that the pupil doesn't change in size in bright or dark. They definitely can increase the risk of glaucoma. So most of the publications describe outcomes at 6 months or a year, whereas the problems, I think, are more in the 5 to 10 year time frame. So long-term follow-up with these devices is absent. And because the pupil can't change in size, it can be significantly difficult to manage any further complications should they occur, such as retinal detachment, or to perform YAG laser capsulotomy, that's the laser to clear the visual axis, should that be required. And so that may mean that procedures which were performed by laser may need to be done surgically. They are expensive. The human optics types or the foldable types, approximately £3,500 per implant, and normally they can be obtained through the NHS, but not all health providers will agree to that. NICE, which is the National Institute of Clinical Excellence, have considered artificial implants, iris implants this is not cataract, this is iris implants. So this is a body in the United Kingdom which considers the evidence for or against devices, in this case iris implants, and their conclusion as of July 2020 was that the evidence on the safety and efficacy, so how safe or how good are they, of iris implants for congenital aniridia is inadequate, both in quantity and quality. So there's not enough evidence, and the evidence that there is not of high enough quality to recommend routine implantation of these devices in aniridia. That doesn't mean that you can't do it. It's a recommendation that centers that do it should be monitoring their results both in the short term, particularly for patient-centered outcomes, and also in the long term, in the 5 to 10 year time frame, to look for long-term problems. There are alternatives to iris implants, contact lenses painted to look like an iris to reduce the amount of light entering the eye, but they can be difficult with patients with reduced vision to manage, to clean, to insert, and if the eye is rough or dry or irritated, they can be difficult to tolerate, but there are alternatives. So a summary statement, firstly, cataract surgery, it's a safe and effective intervention, but it needs to be discussed with your specialist as to the appropriate time to do that. Iris implants, I think the jury is out. They can have a good cosmetic effect, but there is no, I think, firm data on the long-term safety, which I think is a primary concern with most individuals. Thank you for your attention.